Hey y'all, and welcome back to the latest episode of Code Brew. I'm Joe King, and I'm here with my co-host.
Hey everybody, it's Lukewarm.
And we're excited to be back. It's January 2025. Happy New Year.
It's not exactly January 2025.
Okay, well, right now it's December 31st, but whenever they hear this, it's going to be January 1st, 2025.
Fair.
So tell them Happy New Year.
Happy almost New Year.
Oh my God.
Quite very technical.
And I know you've all got all your goals in a row from last week. Everybody's got new goals. We've got all sorts of things we want to accomplish this year. We've got our New Year's resolutions, all our ducks in a row. I promise I'm going to work out more, lift weights more at least.
Gosh, I had a goal set for me today. It was not a personal goal, but someone that I was working with today. I'm going to talk less.
You're going to talk less?
I'm going to talk less.
Oh, no, you're going to fail that. We have to have,
for me.
I told you they had to be reasonable goals, okay?
They also wrote push-ups. I had them erase that.
You can do some push-ups. We could work on that.
I had them erase S, so I have to do
a single push-up. Well,
tomorrow. The deadline actually was 1/1/2025.
So they were just trying to get one goal in really quick before the end of the year.
I'm not sure how quick they think I'm going to advance that goal, but
okay,
we could try it.
But you're not going to talk less because, reality, we know that. So moving on from goals, I hope you got all your goals in a row and you're ready. And you are ready to start fresh in the new year. New Year is so exciting. And so we're going to try something new also for the new year. We've decided that we want to have kind of a theme for each month. And we've chosen
mini-series.
So each month, and who knows, we may not actually do it each month, but we do have a mini-series we're going to do for January. And we've got 4 related episodes. So, all tied together with the theme of rapid response, because that's our main purpose is that we in our current job role as we respond to rapid responses, codes, strokes, just emergencies within the hospital. So
what you're seeing at the beds, your role in early intervention.
Yes, early intervention and getting the rapid response team involved.
And then it would be
that's going to be episode 1. That's today.
Okay, what?
I think 2 is code stroke. No. No, that's 3. 2 is sepsis and hypovolemia. We're doing it next week. We're doing it. So it's sepsis and hypovolemia.
So sepsis is a 2-part series, and it's 2 hours.
It's not. We're not doing a 2-hour sepsis. We may dive into sepsis again later on, but we're gonna skim over the top of it. No, we're gonna look at sepsis next week. And then after that will be stroke and the things that sometimes look like stroke. And then the last will be the cardiac arrhythmias. And then we will also go over Code Brew, ACLS kind of stuff. So got a fun month ahead. We're very excited. We want to kind of dig deep into the nitty gritty of nursing, and just talk about things that are really what you're seeing at the bedside. Things that will really help you to maybe notice more about your patients, help you with your assessments and that kind of thing. Anyway, so just a few things we want to go over real quick, our housekeeping things. First of all, our disclaimer, the views and opinions expressed on Code Brew are solely our own and do not represent the views of our employers, professional organizations, or any personal or professional affiliates. This podcast is for educational and entertainment purposes only and should not be considered medical advice. One other thing, very exciting. You ready for this? We have a merch store. We launched a merch store actually yesterday. And I've talked to some people about, how they could help support the podcast. We've talked to some people about, if we would do merchandise, a t-shirt and that kind of things. I'm really learning, and Luke and I both have talked about some things people might want to buy. I mean, it's exciting to get some products out there that you can wear and be our walking billboards and talk about the podcast, get our name out there. But the store is located at codebrewpodcast.myshopify.com. You can also find links on our socials, and we would be really excited to see somebody walking around with some Code Brew swag, wouldn't we?
I'm a fan. It was cute. Comfort colors. That's all I know.
Oh yeah.
Comfort colors.
Yeah,
Comfort
we
colors.
do have
And then I
comfort
saw
color
the
shirts.
fair thing yesterday. I was like, oh, this is really a thing. Comfort colors.
It
Whatever
is.
that is.
Yeah. So it's we have some comfort colors t-shirts. We have some coffee thing. We have like, a coffee mug. We've got a travel mug. We've got a water bottle because nurses love their water bottles. I think we have like a tote bag. So
I saw it. It's true.
it's pretty cool. I mean, yeah. I mean, it's exciting though, right? So a few things for goals today. We want to build some confidence for you in recognizing the signs of deterioration in your patients. We want you to know when to call for help and feel confident calling for help. And we also want you to be prepared and know some tips on how to communicate effectively whenever you do have a patient that is, when you're calling a rapid response or calling a doctor for, deterioration or that kind of thing. Okay. So the signs of deterioration, we want to talk about what's happening, physiologically, changes that you can look for. We want to break it down by system to make it a little bit simpler. So from a respiratory standpoint, what are those symptoms that we're looking for when you're evaluating someone from a respiratory standpoint?
So I would say increased respirations, decreased respirations.
Right.
Increased respiration. So maybe we've got a metabolic issue. Maybe we are trying to blow off CO2, but maybe unsuccessfully because they're shallow, right? Decreased respirations. I am thinking maybe sedation. So do they just come back from a procedure? Did we just recently change like their pain meds? Have they gotten, Ativan, some kind of benzodiazepine, something causes respiratory depression? So got a benzo, I'm going to give them some asthma, potentially I'm going to give them something to the antidote. Maybe
self-medicating,
right? So that's toxins. So, obviously if I went in and somebody was only breathing a few times and I hadn't given them anything recently,
you have to suspect those kind. You have to at least consider that as part of your differential. Yeah.
Protocols where, you can just give Narcan, to reverse opiates in the event that somebody had taken it. And then just plug for that. Just know, there's refractory respiratory depression. So while somebody might wake up and, start breathing and look good, in 10 minutes, they might be right back into...
Because the antidote burns off.
Yeah, they might be right back into that state where they're not breathing very frequently, and it's like, well, hold on, they were just fine. So there's that repeat dose. You want to keep monitoring. Might need to do that multiple times. Obviously, provider. I think we also want to be cognizant of we frequently, we give all these medicines in hospitals as we mask things, so like you might
normalize things.
Temperature, you're giving, Norco, you're giving, scheduled Tylenol for something. So it's not picking up a temperature, which, would be something that might indicate an infection, right? But we're not seeing the elevated temp or the low temp, so that, being said, like, I'll talk to students sometimes. I'm like, hey, does this patient have hypertension? And they're like, no, their blood pressure is 170, we're 76. And I'm like, could they? Like, no, like the blood pressure is great. But we're giving them 3 antihypertensives and they're on a diuretic, right? So they don't see it, but it's because we're treating it and it's controlled. Right? So their medicine's working. That's great. But I think like it also takes that same type of thinking to realize that like sometimes something can be wrong with somebody and we can't see it because we're treating it, whatever. I think we would need to look at oxygen also, and, like, the ability to go up on oxygen and titrate oxygen up. So their SpO2 might look great. It's 98%, but I started out on room air, started out on 1 liter, right? And now I'm on 6 liters. So it's a pretty significant.
It's so easy to turn that knob.
But when
it's like you don't think about the repercussions there.
Yeah, but when you're seeing, like, hey, my heart rate's 99 and my blood pressure is normal, and it's like, we have a heart rate's normally 60, and while those both are within a normal range, like, I mean, 99 is a lot higher than 60, so that heart looks a lot different, still in normal range. So maybe something's going on. The same with the oxygen. While I still have a normal number, have I done something to make it normal, and something that's like significant enough that, having to keep going up to get these numbers. I need a note of it. I need a nursing consult, right? There are a ton of services in the hospital, so we have kind of like nurse consults we can do. There's charge nurses, there's grab a friend, there's call a provider, whatever it is. Whatever your hospital has set in place. Maybe you have questions about that. What else, like respiratory wise? Like if you had a patient that was, your COPD patient, they come in and you've got them on 2 liters of oxygen. You walk in there like 100% and they're lethargic. That's probably
they're retaining,
CO2,
hypercapnia,
right? So those are kind of like the things that I think about respiratory wise.
Well, you got to think like, hey, did they wear their CPAP last night or their BiPAP or whatever they're on at night? Did they bring it to the hospital? Did they forget it? Did we know they were on it?
Yeah.
So those kind of things can happen because patients sometimes don't communicate those things to us. They don't think about needing to bring their BiPAP or their CPAP machine to the hospital.
So, we need to mobilize our bodies and mobilize our secretions and pulmonary toilet and things. So we have pneumonia. So then we're talking about lungs, right? Blood going by and trying to pick up oxygen, but it's, there's like a block, like, you can't pick it up because like there's areas of the lungs that are like, hey, like you're not going to get good oxygen when you pass me blood because I have an infection. So we're kind of like preloading the blood. It's so great with oxygen. So when it goes through the whole body and everybody's like, mine, there's, maybe not enough for everybody. So I think those are the things that I would consider, respiratory wise. What else?
We written down it.
You look like
right.
So,
no, we'd written down.
Are you wheezing?
Yeah.
Like so.
What
wheezing,
can you hear?
What are you doing? Like,
are you coughing? Is it a trach patient? Accessory muscle use. We had written down. There's so many things from a respiratory standpoint. Put some ears on the patient. You put your stethoscope on the patient, listen to them, and see what you hear. Cardiac wise, from a circulatory standpoint. Yeah, I'll kind of take this.
I'm always thinking perfusion.
Hypotension. That's the one thing I'm looking for.
No.
And a lot of times, from a rapid standpoint, that's when we get involved, is when the patient's blood pressure is low.
And I'm MAP driven. So, like, as a cardiac, like, I'm like MAP 65. As long as I'm MAP 65, I'm like,
that's your magic number.
Where some people are like, but they're systolic 90, and I'm like, but they're MAP's 69 and they're talking to me and they're,
Well, and that's another thing. That's a good point, though. Mentation is a good way to evaluate someone whenever they have low blood pressure. Like if they're able to talk to you just like, a normal, like their normal, baseline mental status, then they're probably perfusing their brain. But if they're not, if you have somebody who's suddenly, more lethargic, or slower to respond or something like that, it may be because they're not getting adequate perfusion. So, somebody who's recently had a stroke and their blood pressure is, we sometimes like have some permissive hypertension in our stroke patients after the fact. And somebody who's, MAP drops down, their blood pressure drops down to, 90s over 50s, their MAP may be okay, but because they've had that drop in blood pressure, they're having some difficulty, some repeat stroke symptoms.
It is very patient specific. You're right.
So it's like very cardiac, patient specific.
Nurse versus neuro nurse, and
there's so many things to look
follow
for.
your protocols and parameters, and what the, you've got to look at the patient. You've got to know the background. You've got to follow your orders.
You always have to look at the patient. I think it's easy to fall into that trap of you're treating the monitor, you're looking at the monitor instead of the patient. which goes back to, we forgot to mention this in ref story, but you have to make sure your pleth is good. If you have a low O2 set and you don't have a good pleth, then the O2 set may not be accurate. So you have to, make sure you're not treating the monitor. But from a cardiac standpoint, you're looking at,
or it's not just laying on the bed. Yeah. So it's loose.
Yeah, no, for sure. Yeah.
So that's 50 bro, just like it's laying in the bed, it's loose, or the heart rate says 252 on the SpO2.
And the patient has a tremor.
75 on the monitor. So
there are some things that can, one of the things that I've had patients really throw me off. I come running to their room because they, have like started tapping on their telemetry monitor thing, and it shows up as VTAC on the monitor, and you come running in and they're just tapping.
Or like the gastroparesis, like when the stimulator goes off. Yeah, and it shows all those like vibration marks. Like, what in the heck?
Well, that's not, so you go in there and your patient's like, what? I'm fine. It's probably because...
How else? So like, yes, I'm going to get a blood pressure on my patient, but like, what else am I going to look for? Like, like assessment-wise, like, like I would probably, if somebody was hypotensive, I'm probably thinking their whole diminished pulses.
Right.
I'm
going to go look at their lab work.
Refill.
Yeah.
So, like, what orders would you anticipate? Like, what could we...
Oh, my gosh. Well, one of the things that I always ask, and I always want somebody to know the answer to is, I'm like, are they a CHF patient, right? Can I give them fluids? Are they a renal patient? Can I give them fluids? So if I come in and your blood pressure is low, the first thing, this is kind of my ER background and, the time I've spent in EMS, like, I want to give them some freaking fluids, because that's a Band-Aid for everything, right? But there are some patients that you can't. You'll kill some people with fluids. So, like, I ask those questions, but, anticipate orders, just for lab work. See if their H&H is low. Do we have a volume issue? Do we...
Or are they responsive? So, you could...
Yeah, that can be,
lift up their legs, do a fluid challenge.
Right.
Throw the fluid to their heart, see if it increases blood pressure.
Orthostatic hypotension or positional hypotension, we see that a lot. If you've spent a lot of time in the bed over a few days, you stand up really quick or sit up really quick.
Did it just drop because there was a position change? Notify someone.
It's really common for our patients in rehab, right? So that's something we look at. But given somebody fluids can be very diagnostic. Absolutely. I love albumin too.
I'm a fan, I guess, with liver patients, so, third spacing and the utilization of albumin to pull that in and create volume in their tank and push it out. Help them not be so puffy and have a little bit of urine is nice. But, it's a quick fix. It's not a prolonged, permanent fix. I really like the liver. That's another thing. So
I do like the liver.
We won't get on there too much right now, I guess.
We do see a lot of liver patients. So I think that's one of the reasons we'd like, A
lot of people have.
Everybody has a liver.
Fair.
Everybody's carrying one around. It's not, you have to have
one. What about like neurological? So neurological is like, I feel like that's the biggest. So
it's so complicated.
It's for sure like hypotension, neurological. Like those are like the two biggest rabbits in my life.
Oh yeah, absolutely. A change in mental status or someone who's hypotensive. Or,
so we talked about change in mental status.
We need to talk about it. Yeah.
Okay, so like change in mental status. So everyone is probably like stroke. Great, think about
Which
it.
Could be.
Because want to,
rule it out.
Time is very, very, very important.
Yes, for sure.
I heard a quote once, and it was like, the goal of stroke therapy is to minimize disability. And I was like, oh my gosh, minimize, like, just to think like not curative, but just to decrease how disabled so going to be disabled. And okay, yes, there's TIAs and there's RNDs and there's great stroke rehab programs and whatever. But just when I heard that quote, it just really hit. I don't know.
No, absolutely, I agree. You're losing brain, so you're losing some sort of function, and the whole idea is to be able to stop it.
So acute neurological change, go stroke it.
Yeah.
What do you want to have? So I really think that people have like the stroke down. They have, I know because we're going in and we're like, oh, what's their blood sugar? I know they're hypoglycemia mimic stroke. They're picking that up.
Well, there's a reason, a lot of times, just something simple like a low blood sugar, or to me that sounds simple, can cause stroke-like symptoms, right? So, yeah.
All the way down to like slurred speech.
Right, 100%. So, that's something you have to be looking for. Are they agitated? Is it something more?
But like on top of all this stuff. So like, stroke, we need to hit all those time measures, and that's great. But like people are going to come help them with that. So like, what are new things? So like when we come in that we're thinking about as like maybe like a rapid response nurse that we could teach other nurses, to assess that would cause alteration. So, we talked about livers and we said, we've got a bunch of liver patients. So an ammonia level, right?
Oh, yeah, for sure.
Oh, this patient is, liver failure patient. Yeah. And they haven't had a bowel movement today, and they've been refusing their elect, whatever it is. Their ammonia
sounds
probably.
It sounds like you found your culprit. But you get lab work to verify that. But yeah, that's you.
Yeah, their urine is cloudy as can be.
Mm-hmm.
It looks like an infection.
And UTIs will make people really struggle mentally, especially our elderly population. You really have to consider that as part of your differential, because
an elderly and just infection in general, right? So we always say little lady, she gets wild and crazy with the UTI.
Well, the UTI is your most common.
And that's what brings them into the hospital. It's like grandma got wild.
Yeah.
And grandma usually just makes pies, right? And loves on everybody. But what? That's what grandma does.
But when grandma comes into the hospital, she is wild.
She is.
She ain't baking no pies. She might be throwing punches.
Baking pies. But so infection in general. So when we think about like sepsis progression, which we'll talk about, and sepsis is one of my other passions, I guess. We know that that progresses to hypotensive state, especially when we get to severe sepsis. And with that, we're going to have hypotension, maybe poor brain perfusion, right? So we don't have enough blood pressure, to move up and perfuse our brain. So that's another thing. So with infection, I'm always going to think, are they hypotensive? Like, what does that look like? Do they have a GI infection? So that's also fluid, or vomiting, diarrhea. So another blood pressure issue. Another thing that's throwing your left whack. So that's confusion, right?
Well, and you might be seeing some other stuff with that too. You might be seeing tachycardia. You might be seeing. There's so many things. It's very patient specific, and and the one thing we have to reiterate, I guess, is nobody presents the way they do in the textbook exactly.
I think I would throw hypercapnia on this too. So when we talked about it with respiratory, but that COPD patient, or just anyone that's retaining CO2, usually when
anytime you see lethargy, you have to include the possibility of hypercapnia and grab that ABG and see what you're dealing with.
Differentials. I always explain this to like we're not gonna so if a patient comes in, they're complaining of like chest pain and like shortness of breath and whatever. They've got pain, they've got shortness of breath. Let's just use those two symptoms. And are we gonna, in the ER, are we gonna say, okay, let's work you up and wait for those labs? I don't know.
No, you start with an EKG.
Well, you always have like a differential, right? Like you're also like, oh, hold on, like short of breath or like oxygen's low, like also be a key, right?
100%.
So we don't want to just like work up one thing all the time. That's why I'm going through these. So like when I'm saying neurologically, it'd be related to hypercapnia. It could be related to hypoglycemia. It could be related to a stroke, which, and we very timely.
Well, I mean, that's one of the things
it
you
could be
expect.
related to an infection. So what does their urine, what does their lungs look like? Have we been going up on oxygen? So increased demand is probably telling me if I've gone from 1, 2, 3, 4, 5, 6 liters, I'm on oxidizer, whatever. Maybe we have an pneumonia. Next,
Right.
so that infection, that preload of oxygen is probably more. What does that blood pressure look like? So that's like the checklist.
Yeah.
This is the checklist I'm doing, so you can understand maybe my weird brain or something.
That weird is right.
But delirium, oh my gosh, delirium, like in the hospital,
Oh gosh, yeah. Maybe that's what's wrong with me. I have delirium because I spend too much time in the hospital.
Well, I mean, you're not at your house.
I know.
I mean, people are like, emptying your trash can, and you're like in this little.
They draw your labs at 4 a.m.
When somebody comes in, they do an assessment, and doctors are running all these different times, and they want you out of bed, which you need to be out of bed. You need to be out. You need to be mobilizing. It's like sleep. Like somebody was in here, around it, and I'm always just kind of like, I don't see me, then I'm not seeing me. Like what facials, man, like your dad.
No, I remember that. Like when my son was born, I was like, "Oh my gosh, we have to leave. We can't stay here another night. We have to leave. I can't. If they come back in here, I'm gonna."
People have been here for a month or
I
something.
know. I can't imagine. I mean, I honestly can't. I go crazy. I don't do well without sleep either.
Well, you've been here 2 years, so crazy.
I know for sure, 100%.
12, 13, right here.
Yeah. So let's talk about some tools that help for early recognition. I feel like those are really important. I mean, this is something that we've seen, since the, transition to the electronic health record, where we have these different things.
Data miners, yes. Chat GPT, I guess there's we have tools in the EHR, EMR, whatever you want to call it, that are actually like looking for clinical deterioration. So they're looking for, this person is requiring more O2. This person's SpO2 is decreasing. This person's heart rate is increasing. Their blood pressure is decreasing or increasing.
Their temperature is going up or down. I mean, it's looking at everything.
A lot of these are, it looks at labs too.
Well, Muse does not. But some do.
Tool.
Yes, the clinical tracker tool does, yes.
In general.
There's different tools, yeah.
A lot of information and triggers for you.
Which is really, I mean...
It's just nice. I mean, like, it even says, like, on, like, the sepsis when it pops up, it's like, consider.
Right. I mean, you have,
it's driving care in some capacity.
You have, there's something that'll pop up, be like, hey, we think you might need to consider sepsis for this patient. It does that for you. Or, our system uses the Muse, so it pops up and it says, hey, this person's triggered a Muse of 6 because of this, this, and this. You need to look at them.
And something that it could be vital signs that are just not charted.
Right. I mean, it could be an error. I mean, there's always that possibility.
To have you've got people that are, while somebody's baseline Muse might be a 5, which is over, a limit where we were
the threshold.
It's really nice to know that you have this backup. Now,
an extra pair of eyes, yeah.
It requires people chart in time.
It does. Yeah, so if you back chart 3 hours, that's not super helpful.
You could get an alert 3 hours later.
Right.
Now, the nurse still is the one responsible for providing care. This is just a backup to go and say, hey, did you give a second set of eyes in your patient? I got in the chart. notice this PRN medication. I saw that you gave it, or, what do you think about giving it? Having that discussion with them. Ultimately, they're still the person that's, responsible for the patient and driving care. But it's a really good support system.
Oh, yeah, I think so. I think it's tremendously helpful because, whenever I started, I'm sure the same thing when you started, like, we didn't have that. Like, we didn't have someone, we didn't have any kind of backup. Like, we had to really look at things on our own and know what we were looking at. I think it can become a crutch in some ways, but it's also helpful because we're dealing with people and, the human element is that errors are possible. So if we have something that, is more difficult to trip up. But all that to say, knowing your patient and continuously assessing them and knowing what their baseline is. So you assessing them multiple times every time you look at them, basically, so that when something's changing is.
Well, I think
really
I always try to do a good job of. I'm not going to be great at charting like my full assessments in real time, charting the vitals in real time. So defaulting, get that time stamp in, and if it needed to trigger someone to come in and see my patient, they'd probably be like, oh, he's going to tell me to go away or whatever. But, it's for sure helpful. Also just kind of like knowing, when sepsis criteria. So I know sepsis is like a whole nother lecture, but I always just generally memorize in my head. So this is a very general sepsis criteria. So it's kind of like what to students. If you have 2 abnormal vital signs plus a suspected kind of source of, so this is exactly true. So let's say you nurse, doing all my assessments and passing the meds, I'm not going to be able to chart it. But just know that if you see, a heart rate that's a little bit weird, it's high and the respirations are 24 and the urine looks weird, we probably have sepsis. We've met criteria, right? So we have a suspected source of infection, we have a living rate, elevate risk injury. So might be able to just know when you're looking at the sheet, and I just like write down my vitals and like my assessment, my pulses, and whatever, trying to be organized as an like just kind of like almost sort abnormal medicine. Like, oh, I've got 2, you're like crazy. All right, this needs an intervention now. So that was something that's helpful to me, anyways.
So I kind of want to move on to our next topic, which is like when to call for help. So you've noticed something's off, right?
Called in,
and so I feel like there's a hesitance, right? Like there's this, and people want to do things on their own, I guess, maybe, or maybe they're scared to call because they think somebody will make them feel stupid. But like for me as a rapid response nurse, like that should not be how we behave. Like I want to be a resource. I want you to call me.
That's so that's every day. So that's like when you're on the floor and every interaction that you're having, you need to train. And then it's very simple. We need to make sure that we're always accommodate. They feel comfortable. Hey, like come look at this. I think that's like one of the benefits to having like this team, because they don't have to call around. You can say, you can look at this patient quick. It doesn't seem so big. It doesn't seem like hospital, come to see this patient.
Right. Anyways, not something that's going to be paged overhead. Yeah, you feel like you can.
Doctors are coming, whatever it is. So I know that I felt. I don't think the hospital made me feel this way. I felt as a new nurse that I was like I'm going to be judged if I call this. And it's like they're going to be like, hey, it's just this, or whatever.
But if you can't get there,
an environment that welcomes questions, urges safety,
right, I mean, if we have a new grad,
have a concern, escalate it. I think everyone, like, for any concern that you escalate, as I'm leaving, I'm like, I appreciate yes. Definitely want to catch something as soon as possible. When you start talking about sepsis, when we talk about like with sepsis, every delay in the administration of antibiotics is like a increase in mortality of 7.6, 7.9%, something like that. But you got
you gotta escalate. I mean, even if you're a new grad and you're afraid of being judged, the thing is like, I'm gonna know that you're new to the game, right? You can have a discussion with me. You can say like, hey, I feel like something's not right here. I'm not sure what it is, which is why I called. I'm gonna be okay with that. I'm gonna say, I'm glad you did. Either we're gonna figure it out, and we're gonna learn something from it. Because I'd rather you call me if your gut says something's not right. I'm not really sure what it is, but something's not right. I'd rather you call. Just call.
Hell, tell me what it is.
Yeah.
We all learn something.
Yeah. You just never know. And if your knowledge base is not there to the point where, you can't pinpoint an issue, then call somebody who has the knowledge base and then keep calling more people until you finally get to somebody that can figure it out. Right? So,
I learn every day.
Yeah.
Still.
Well, you kind of have to. This is such an healthcare is such an evolving industry. There's something new.
Yeah.
Every day, it seems like. Month to month, you're never quite sure. They come out with new stuff. We're all still celebrating
virtual nursing.
Virtual nursing. Oh, yeah. Virtual nursing is happening. But we're all still celebrating the PureWick catheter. Gosh, it's the greatest thing that's come to nursing in the last 14 years since I've been in it.
It's the prima fit.
Oh, whatever.
They've already expanded their
I still say it's the PureWick. So, but no, I personally am also celebrating the advent of jogger scrubs. There's something new coming out all the time. So
call it. We
yes.
talked about when to activate. Said to call it.
So things that we
So you've called it, and what is going to be most helpful? This is when the people arrive.
It's a great question.
What do you need? I want a computer open. I want a computer open.
I definitely want a computer open right there. I want
the primary nurse there. Answer some questions for me.
I always want a blood sugar. I always want to know the patient's history. I'm going to ask you, probably the first thing I'm going to ask you is what is this patient here for? Why did they come to the hospital in the first place? Because that's going to give me a good idea of what we're dealing with. If they came to the hospital because they needed their leg amputated, then, I'm going to kind of go off of, okay, this is what we've done so far,
To have vital signs. It's the same thing.
Vital signs.
For a pattern. So
SVARs are great. If you have your SVAR right there.
Vital signs.
That's it. Amazing.
Some pertinent background, what we're here for.
We're always going to look at the meds.
Contact the provider. What meds have we given recently? A lot of what about PRN? Oh, we got to treat those. We do.
Yeah.
We have a med.
We suggest that you do this that's already in order.
Q6 hours for, hypotension or whatever it is. Look at your PRN.
Or our psych meds, somebody who's suddenly agitated and
they've been getting Haldol pretty quickly.
Yeah, we could probably give that again. Or, we know they sundown or whatever.
Look at your PRNs.
Yeah.
Know what they're for. That's stuff you also be talking about. That's a shift report.
For sure.
So I would say that's definitely an area to hit. What are PRNs? When can they have them again? Not necessarily just pain notes. I think we do pain notes, and maybe there's opportunities to talk about some of the other PRNs. So I want a computer app. I want to review labs.
labs and meds.
History.
I'm probably going to look at like,
provider notes.
Yeah, the most recent provider note.
EF, things like that.
Yeah.
Depending on what the situation is. Current imaging. Are they on antibiotic? A computer's really helpful. A nurse is really helpful. Someone to.
Oh, I definitely want the nurse. I want the primary nurse. Like, I mean, this is something. To call
the doctor.
It does happen sometimes where like somebody calls a rapid, and then I get to the room and there's like, it doesn't happen that much, to be honest. But every now and then, like, I'll come into the room and there's nobody in the room, and it's like, who called this rapid?
It's for you.
I need someone. I guess I'm just here to save the day. I just got to figure it out. No, like I have questions. I mean, so I have some nurses that they call a rapid and I arrive and they immediately just start spilling off all the information that I need. And I'm almost like, slow down, but they know everything about their patient. And that excites me.
I love it.
It excites me. No, the more you know about your patient, the more excited I'm going to be. So, and I will say, like, I do get a little frustrated whenever somebody's like, says something like, I don't know, it's not my patient. Okay, well, just tell me who it is. Like, or, I don't know, this is my first day with the patient. But it's like, 1:00 and you've been here for 6 hours already, like, and you still don't know anything? That's concerning, But that's okay. Pull up the chart. We're still going to take care of the patient. But no, I want...
I think some of that is like shock. Like they know.
True, that could be. Yeah.
But
I don't want to be intimidating for sure.
Like, oh my gosh, this is like an emergency situation. Like I think you sometimes just go into like the shock state when you don't experience it all the time.
Right. Well, that's one thing. We bring the calm.
You're like, oh my gosh, hold on, what? And that's why we have these support systems.
Right. I mean, we bring the calm. Like, I try very hard to be just, as calm as possible. I mean, I'm going to bring some even keel to a situation. I mean, I am one of those people, though, like, if I get riled up, then everybody else should already be riled up,
I can see that.
Yeah. Yeah, I mean, that's me. By the time I get upset about something, no matter what kind of upset it is, like, But no, the S-bar, you did make a good point about the S-bar. I do want the S-bar to be, that would be really helpful, especially for our new grads. Like, if you have that kind of information in front of you.
So, like, wrapping everything up, what are you saying?
I just think it's important that people understand kind of how we approach things, like kind of the checklist that we're going over in our head, the different things we're looking at.
So I think personally I need to do a better job sharing that with people.
Probably so. I mean, now that we talk about it, I think it is helpful that we, definitely from a teaching standpoint, that we start like, because those are all teachable moments whenever, as best you can.
This made me realize I do a bad job. Like I was thinking about the other day, I was like, people ask me to start an IV and I'll be busy. So I'll get it, and it gets the time where I can go and start it. But I need to start saying, you're going to go on there with me. Like we'll start it, but you're going to go on there with me. I'm going to make sure that you know how to do this.
Right.
You know what I'm looking for.
So these types of assessments,
making sure that's a learning experience.
Right. Because we can teach while we're taking care of the patient.
So that was something that I realized was an opportunity for me. That'll be my goal. So that'll be my year's goal.
It's to talk more.
Start grabbing people and taking them to university, and I'm going to talk out loud and go through all of the systems and what it is that I'm.
I definitely could too. I think I get so excited when I see students and I grab them and just start asking students, and I quickly grab them and start asking different things. But then like our experienced staff at the bedside, like they may need some of that too, or they may want to have those kind of questions, and we haven't done it. So
we're so busy. I mean, gosh, I remember when I worked the floor, you have 4 or 5 patients. I always wanted, I would see like, I don't know, my friends in the ICU, like I would hear like the conversations that they had with providers, and they were like long and detailed and like educational. and there was, talk and forth, and they're growing the nurse. Whereas, I have so many different patients with so many different, disease processes that, I would hear a history and I was like, I'm gonna go and look this up when I get home. I don't know what this one was, whereas they were able to talk to a provider about it. They're like, oh, what's this? Blah, blah, blah. So there was like a growing in the ICU. So, it's a little bit harder when you have a ton of patients to know everything about every single one. I mean, like we know, like you're an ICU nurse that's like back in 1800.
It's just from you. It's not everybody else. It's just from you.
Okay. Well, back in 1800, their grandmother, yeah.
It was on the Oregon Trail.
What was going on in 1800?
Had dysentery. Yeah.
Had dysentery. Yeah. Yeah, it's fair. I mean, those reports are a thing though. And I know, like working on intermediate floors, like I did want to know more, but sometimes that time wasn't there.
Because you have more patience.
Grow me. Like, I'm going to say it over and over again. If I'm growing an organization, I'm happy. Last thing I wanted to, just some mistakes to avoid whenever you're a patient, when you think your patient's deteriorating. The first thing we keep talking about is don't wait too long to call, right? If you think something is happening, don't make the mistake of waiting too long to call. Call it.
Yeah. The other thing is don't fixate on one thing and miss some other things that could be going on. We get kind of like we notice that a patient is breathing really rapidly and stuff, but we don't really notice that their blood pressure is starting to go down, or we, start turning their oxygen up. We don't realize that we're, causing their CO2 to be held onto or something like that.
Or they're breathing rapidly, but they had Lasix to 20 minutes ago.
No, yeah.
I'd be Lasix to 20 minutes ago.
Yeah, look at your PRN.
Like, that we could give.
For sure.
That would fix it.
And we, and just remember, we are dealing with human beings, and they're not cookie cutter. Like, they're not going to present exactly how the textbook is. You kind of have to expect the unexpected. When you see signs and symptoms, you think common things, but there's also a possibility that it's something way off the wall. I mean, it happens like that. There are going to be things that you miss, and it may not be because you really miss them. It just is because they didn't present in a normal way, right? Like we've learned over time that women don't present with chest pain, but they have MIs.
Gosh, I read like a statistic. I was like teaching a class on ACS, acute coronary syndrome, and they were like, I've looked this up since then. I did not get the same information, but at the time, this was a few years ago, they said more often than not, women find out that they have heart damage because they've like gone to like their primary care doctor or a counselor for anxiety. They think there's something like psychological going on. Like, oh yeah, like my anxiety's out of control. And they're like,
I mean, sometimes it presents almost like a toothache. Oh, I got jaw pain.
You've actually had a heart attack,
right?
Which is interesting. And all those, there's all those different types of the geriatric silent heart attacks and all.
Diabetes can cause that kind of things too. Yeah.
Whole topic.
Oh yeah.
Was interesting.
It's impossible to detect everything, but we do the best we can, and always look out for, call for help if you need it. Okay?
So our call to action is
early recognition saves lives. No? You like that?
Yes. Ma'am mix a lot. I don't know.
No, I don't like it. No. No, I think what it is more like if you think you may need to call a rapid, then you probably should have already called the rapid.
Anytime you think that you should probably do something, you
probably should. Trust your gut. Yeah, that's a good one. Trust your gut. So, a few things to wrap it up. Don't forget, we have Code Brew merch at codebrewpodcast.myspotify.com. and be a walking billboard for us. That's really exciting. Next week we're gonna
be somebody.
I'm
almost buying over people just so you can see people at them.
If we were out and about,
yeah.
If we were out and about and we saw a stranger wearing a Code Brew shirt, we would both probably just like fall out. We would be so excited.
She might buy you dinner.
Luke wants to sign it.
Talk about it for the rest of her life.
He's got a Sharpie in his pocket ready to sign.
Absolutely
he's
do
giving
not have a
autographs for
Sharpie
sure.
in my pocket. I do have a Sharpie.
Oh yeah. So next week, like I said, we are going to do some sepsis. We're going to look at hypotension. And those are some very common signs, some common causes for patients crashing. So we're excited to get into that. And like always, we want you to stay caffeinated and stay curious. And we'll see you next time on Code Brew. Bye.
Bye, everybody. Happy New Year.